Can you guys see my screen?
Yes.
Wonderful.
Yep, perfect. Okay. So I'll get started. Well, it's my great pleasure to introduce my good friend and colleague and collaborator, Ali Rezai, who, as you see, is currently the John D. Rockefeller IV Neuroscience Chair, Executive Chair of the Rockefeller Neuroscience Institute of West Virginia.
Recording in progress.
Ali was a medical student at USC, and then I met him when he was a resident, actually, at NYU when I was applying for residency, and even then he was a memorable figure. And so I don't remember much about interviews, but I do remember meeting Ali. After his residency, he went on to the University of Toronto to do a fellowship in functional neurosurgery, where many of us followed in his lead over time. And then he came back to NYU for his first faculty position, where he was directing functional neurosurgery. After that, he went on to Cleveland Clinic for a while, where he was running a neuroscience institute there, and then eventually went from there to Ohio State, where he was an associate dean and was the head of a neuroscience institute and a chair in functional neurosurgery, and then finally came to his position here. He is also past president of the American Society for Stereotactic and Functional Neurosurgery. He is past president of the Congress of Neurological Surgeons. He has been a prolific innovator in our field for decades, and a real pleasure to work with, and somebody who I really value his contributions both to our own work as well as to our entire field. So it's a distinct pleasure to have him join us today. Thanks, Ali.
Thank you, Mike. Great pleasure, and thank you for the invitation. It's an honor to be invited for this with two esteemed departments of neurosurgery under Phil Steig and Sandra Connolly. So phenomenal group here, tremendous science and clinical work, and my old friends also, Mark Sudane and many others. So want to send my best to everybody. So it's a great pleasure, and thank you, Rupa, for the invitation as well. So want to take this opportunity and present some of the work we're doing in focused ultrasound. And you already have Mike Calpit, who's an ultrasound expert there. So he is one of the pioneers in this field from the work he's done. And Gordon joined you guys also. So you're going to have two of the top people in ultrasound here in your institution. So it's fantastic. But I was going to talk about current and emerging applications of ultrasound, and please interrupt anytime with questions. So continuing on, can you see my slides, everybody, by any chance? Yes, very good. And can you hear me okay? Very good. So focused ultrasound, there's a lot of activity going on in neurosurgery. This is a nice paper. Really started in the 90s when the FUS was combined with MRI. And that's really changed ultrasound. I'm moving from a single array to multiple array technology. And these are, Kullervo Heinen was one of the pioneers, along with Nathan McDonald at Brigham and in Toronto, that really spearheaded a lot of the work with MRI-guided focused ultrasound and some of the pioneering work that led to the work that we see now routinely being used. So really, it was coupling the ultrasound with an MRI that really transformed the technology, allowing us to be able to target specific parts of the brain. Continuing on here, so there are many, many systems out there, preclinical systems, hundreds, local custom-built systems, one array, multiple arrays. So it's a lot of research out there. Clinical systems as well, there's multiple investigational devices, handheld devices, Burr-hole devices, the Carthera French device being used for tumors, as well as other device technology that's being used, but really the only FDA-approved system for human use is Insightic. So I'm going to focus the main part of the presentation on that, except when we talk about preclinical work. And the evolution for contemporary use was when they moved from doing a craniectomy to deliver the ultrasound energy to having no bone opening, and this contemporary transcranial focused ultrasound. And Kullervo and Nathan McDonald are the two pioneers in this that really brought the modern age of focused ultrasound with MR guidance. And this is a very important paper in 2010 that looked at initially for lesioning of brain tumors using focused ultrasound energy. The current system that's approved is the MRI guided systems in 2016. Is approved for unilateral essential tremor. The technology provides new opportunities for neurosurgical interventions. Lesioning, so there's three things. There's lesioning, there's blood-brain barrier opening, and then there's neuromodulation. So lesioning is FDA approved for tremor, Parkinson's and essential tremor. And there's clinical trials underway. We'll talk about that for Parkinson's, dystonia, epilepsy, chronic pain, OCD, and depression. Blood-brain barrier opening is one of the most exciting applications of focused ultrasound. Clinical trials in Alzheimer's, Mike and I doing the trial, Parkinson's trials ongoing, and targeted drug delivery in brain tumors, and targeted the delivery of gene therapy and others. And then the third component is neuromodulation, where you're not making a lesion in the brain and you're not opening the blood-brain barrier, but you're delivering a small dose to do modulation temporarily. So the MRI effectively becomes a therapeutic tool in addition to a diagnostic tool. And that, I think, is a big, big innovation in neurosurgery. So the lesioning approaches, so those are the most common right now. And that is a higher frequency, 650,000 hertz. And it's focused ultrasound, and that generates focal heat that ablates the targeted tissue, initially used for tumor targeting, and now it's used for lesions for functional neurosurgery. And these are the applications. We'll talk about those. The second component is blood-brain barrier opening. It's a 220 kilohertz system. It's a lower intensity system. We call it the LIFU, versus the high intensity is called the HIFU, high intensity. And two different systems. And this one delivers a much slower energy. And when you couple it with intravenous microbubbles, you open the blood-brain barrier. And that is reversible and consistent and reproducible. And that's a very exciting area for brain tumors and neurodegenerative conditions. And then the third application is neuromodulation, uses the low intensity system for modulation. Studies are published where you can modulate for waking somebody up from a minimally conscious state, or it's being used for chronic pain or movement disorders. And we have an FDA trial for addiction where we're activating the nucleus accumbens with a paradigm of addiction. So three different applications: neuromodulation, high intensity focused ultrasound, and then low intensity. This is the current FDA approved system. And there's no incision or skull opening. It's an outpatient procedure, 2 hours, they go home. And you use MRI guidance. You can bring in all your anatomical images, and you can bring in your tractography, fMRI, PET fusion, and you have focal and precise treatment of 1 millimeters. And you get real-time feedback where you have MR thermometry, and you can look at your target lesion evaluation live, and you can assess live. And there are 3,000 patients treated with this FDA-approved system. The technology is 2 hours, and what happens is you do your initial targeting here on an MRI like we do typically for DBS or other procedures, a gamma knife, and then you deliver ultrasound, and then you're doing a real-time thermometry. You look at the lesion as well, and if the thermometry looks good, you increase the intensity to make a permanent lesion. So you do a temporary lesion like we did in the old days with radiofrequency, and then you do a permanent lesion. An example, and you can see this is the current system. You lie in an MRI, the helmet comes over your head. It has 1,020 ultrasound probes that deliver the ultrasound energy through your scalp, through your skull, and transmit it to a focal point in the brain. And then you do a low energy first, then you see a tip with the temperatures, and you look at clinical benefits and side effects. If it looks good, then you give a high energy to make a lesion, and you can steer it and move it in different directions: anterior, posterior, medial, lateral, dorsal, ventral. And it's all done electronically. And that's really the genesis of this system, and very effective system. You can see this is one of our patients 3 years ago. You can see it's got severe shaking here, and it's got essential tremor. He's trying to write his name.
Right hand only.
Can you hear the audio?
And if I try to write my name,
yes.
Thank you.
Steady in it a little bit, you can about read it.
Drawing a circle, writing his name. And then after the procedure, this is immediately after the procedure, the tremor.
I'm still afraid I'm going to drop it.
You got it.
I've got it.
So the effects are immediate, and you see the lesion right there, and you can write your name. So people go home same day. So that's a typical case for somebody with a focused ultrasound. A few words about the basics. So ultrasound are mechanical waves. There are sound waves that travel different frequencies. The human ear can hear sounds from 20 hertz to a 20 kilohertz range. And that's a number of sound waves per second. But ultrasound lesioning and neuromodulation typically use the wave frequency of 650,000 hertz. So we can't hear that. Sorry, was there a question? Okay. And ultrasound can be transmitted through the human body with different effects on sound propagation, depending on fluids, soft tissue, and solids. And it has different properties as it travels through these different mediums. These are the FDA-approved devices. This is the front and end back unit. This is the transducer, the helmet that comes over your head as you lie on the MR table. And the company is called Insightec, which has the FDA-approved system. There's been some technological innovations. The transducer composition, that's really important. The transducer changes the electrical signal to mechanical vibration and vice versa. So the electrical signal gets transmitted to an ultrasound and then vice versa. You can receive or hear the ultrasound signals coming back. And it's a two-way technology. And another innovation has to do with the fact the transducer shape converges the beam. So typical ultrasound imagings use a beam that is straight or divergent, and the beams they're perpendicular to the transducer surface. In the case of focused ultrasound, these beams are convergent because of the shape, and they converge to a focal point that can be used for thermal therapies and others. Is similar to light convergence. Another innovation was phase correction, and using algorithms to correct the local skull thicknesses and converge the beams. You can see what happens. There's different phases that are occurring, and you have to get phase correction. So you go from the heterogeneous phase to individual focused areas that allows you to pinpoint a specific part in the brain and tissues. So this phase correction is an important advanced technology. Skull density ratio, very important, and that's a global measure of your skull thickness, comparing cancellous bone to cortical bones. And if you have a low skull density ratio and it's a cross section, so what happens with the ultrasound waves, you can cause a lot of deflection. So it's not as accurate. And so you have more reflections and lower energy transmission across the skull. If you have a higher skull density ratio, it's more homogeneous and you have higher energy transmission across the skull and less reflections in this case. And so we typically like to have a SDR more than 0.4 so we can be more precise. Another area is absorption challenge. Sound waves lose energy when they change in their media propagation. So the higher the tissue density, the higher the absorption. And bone is thicker, so absorbs ultrasound energy much more. You can see as you travel the energy through the bone, a lot of the energy is lost in the skull. And up to 90% of the energy loss occurs before reaching a target, mostly in the skull, that results in skull heating. And that's also an important point. So you require a mechanism to cool the scalp and the skull. So during sonication, the target and the skull are heated due to energy absorption. And then there's a cool water membrane on your head that allows you to cool your head with the cold water at 15 degrees centigrade, circulate around the skull, around the transducer, in between. So for every 3,000 joules of energy applied, 90 seconds of cooling are required. Registration, you all know about this, standard in neurosurgery, register to MRI and CT. And then this is an important innovation is with thermometry. So you can see here, it shows you where you are and the heat map around your target in the brain. You have your average temperature and max temperature, and this is from the console. And this really is important because you can adjust your heating medial, lateral, anterior, posterior, dorsal, ventral to make sure that there's no phase shift in the heating or bleeding of the heat going on. So you don't want to get too lateral, so you can get in the capsule and cause speech deficits or contraction deficits, or getting too posterior in the thalamus causing sensory deficits. So key areas that have led to this innovation is water coupling and cooling, skull phase correction, skull characteristics of a skull density ratio has to be more than 0.4, and efficiency of ablation are key factors that led to this technological innovations for ultrasound. So it's not a surgical procedure, does not require radiation, and couples live MRI imaging with targeting with FUS treatment. Focus ultrasound, FUS, HIFU, high intensity, LIFU, low intensity. So let's talk about essential tremor movement disorder. So again, it's current FDA approved Tremor, unilateral thalamotomy for essential tremor and Parkinson's. And in Europe, it's CE mark approved for essential tremor, tremor dominant Parkinson's, and neuropathic pain. So talking about the FDA approved indication, and Mike Caplet is a master at this. So you should watch him. He's really amazing in what he does, and Jordan Baltic as well. So you have two of the top people there with you in your groups. Anatomical targeting, again, you typically, what I do is 6 to 7 millimeters in front of the PC, 11 millimeters lateral to the wall of the third ventricle, and 1 millimeter above the ACPC line. The target is a little different than the typical DBS target. So you have to be realizing you're making a lesion. It's a little different than radio frequency lesions. So you don't want to be targeting exactly like you target DBS. So we've learned over time with our targeting with this. Right now, it requires a frame and a head shave, but within a year, a shaveless system is coming for BBB opening. I'm sorry, we have a shaveless right now, a frameless system is coming on. And the patients are awake in the MRI, so we can test for side effects, speech difficulties, or tingling or numbness in the extremities, or a metallic taste in their mouth, or looking for ataxia, dysmetria. And we do a test lesion initially, which is not a permanent lesion in the brain. And if it looks good, you see some improvements in tremor and no side effects, then you make a permanent lesion. If you have side effects, if you're feeling tingling with the test lesion in the thalamus, you move forward. If you're feeling speech, if you're getting speech contraction, you move more medial. If you're too ventral, you'll be getting some ataxia or dysmetria, and you move more dorsal to get away from the cerebellothalamic tracts. Thermometry is very important, live thermometry, really nice axials. You can shift it. So if your MR is shifting more anteriorly here or posteriorly, you want to phase correct it here. Sagittal correction and coronal correction, which are MR thermometry, and that allows you to get a very tightly focused lesion on thermometry. So that makes it a really advantageous with MRI thermal imaging. And then you do the thalamotomy afterwards. You do a 50 to 60 degrees, and you make a permanent lesion. You can see a couple of examples of the lesions here with the central necrosis of the lesion right there. You can see afterwards, tremor stops immediately, and they go home same day. And this is really simple and very effective. Some outcome studies, initial proof of concept study published in Lancet Neurologies. 4 patients. This is by Neer, Lipsman Group, and Colervo, Andres Lozano in Toronto, and Sunnybrook. And then the randomized sham control trial, Jeff Elias and the other colleagues did this larger study. Howard Eisenberg and others were involved with this study, looking at the randomized control trial. And this you can see here with the sham and the thalamotomy and persistent improvements at 12 months with focused ultrasound thalamotomy in this case. And then even longer term outcomes, 3 years, improvements were sustained at 3 years. And then even longer 4-year outcomes are being published now. I don't know, Mike, how long Mike's outcomes are, but we have 5-year outcomes in this case right now for this in terms of the my days at Ohio State doing these. There's the results are robust over time. And the adverse event profiles also improved as we got better and understood that this is not a DBS target, but it's a lesioning target. So you have to get away from the ataxia areas and some of the other areas. Adverse effects, again, this is a study that was published. We did it 186 patients across multiple sites. And most of the AEs were mild and transient, and serious adverse events were infrequent. And 1.6% rate of severe thalamotomy-related AEs were reported in this study that involved all the key groups in the country doing this. This is a great paper that looks at the long-term complications. So this is a good profile. It has to do with time and learning curve as with everything else in neurosurgery. So in our experience, now 50 patients that I've done with HIFU outcomes, 80% improvements with tremor control, more distal, and complications most are mild and transient that resolve within 30 days. And ataxia and gait are the most common. They're transient. Some patients, with older ones, we tell them bring your walker with them so they can go home in a walker. Sensory numbness, taste, speech, and motor deficits are rare. The most common is transient ataxia and gait. And permanent complications are infrequent. We have a 4% gait imbalance and unsteadiness, most in the earlier serious, and 5% that have permanent sensory loss with finger numbness, tongue numbness, or taste difficulties. Vast majorities are from the earlier days, and it's reducing significantly with experience. Switching gears, subthalamotomy lesions, location is very important. So there's a lot of technology just looking at if you are the best location, if the lesions are inferior lateral to the thalamus, we had more gait and dysmetria. If they're more lateral, you get more speech. They're more posterior, you get sensory. So this is some studies that are looking at how we can get better lesioning. Imaging, thalamic parcellation is really helpful in terms of looking at the different thalamic subcomponents and help make our procedures more precise. Again, looking at the corticospinal, medial lemniscus, and Mike Kaplan's group does a great job at this, looking at the DRTs and other tracks. The DRT track is very important that comes in from the cerebellum, and that's a track that you want to be right above to get your best outcomes. This is a therapeutic sonications. We did a study, looked at overlap with the VIM parcellated and probabilistic tractography. So we saw a very strong correlation with a good response in the cerebellar input pathways, the DRT pathways. You can see here, pyramidal tract, the VIM nucleus, the sensory nucleus. And in this case, we can get the thalamotomy lesion. There it is. And you can see the pyramidal tract with tractography here and medial lemniscus. So you can see where you are and do a tractography as well as anatomical imaging for your target. There's a research study, Mike's group, Gordon's group, our group, Maryland, Virginia, and Stanford are involved with doing a contralateral HIFU. So it was FDA approved for one side, but now we're doing the second side. The results are very encouraging. I suspect by beginning of next year, HIFU will be FDA approved for bilateral thalamotomies. So that's an ongoing study across 6 different sites that it's ongoing. So this is an example. You can see a very nice lesion. You can see post-op in these cases. This is our first 2 subjects we did with a focal point. This is immediately after sonication, and the results are right there, and immediate thalamic improvements, tremor improvements. Parkinson's disease. Let's switch gears. FDA approved for tremor, and this is JAMA neurology study published looking at this, the UVA group, and again, controlled trial that showed efficacy that led to the FDA approval for Parkinson's tremor. Then there was shifting gears towards looking at Parkinson's disease. Now we go outside of the thalamus, and you're looking at GPI here. And these are recent studies. This is Howard Eisenberg's from the University of Maryland with Reese Cosgrove at the Brigham. Very nice study looking at 20 subjects with unilateral pallidotomies, looking at the motor signs, motor fluctuations, and the total UPDRS3, which is what we look at 12 months, 45% improvement. So nice results. So this is now venturing outside of the comfort zone of the thalamus towards globus pallidus with this. It's not FDA approved, so these are ongoing trials. And then looking at subthalamotomy, this is the Obesos group in in Spain. And this is the first study that was published in Lancet Neurology in 2017. And they saw improvements with the subthalamotomy. The same targets we do with the DBS, exact same targets can get treated with focused ultrasound. They go home same day. And then this is the randomized controlled trial in the New England Journal of Medicine. Great study published last year, December, looking at subthalamotomy with this double-blinded sham controlled trial that showed improvements for those with subthalamotomy at 19.9 compared to 9.9 improvements. So very strong, encouraging results that are consistent, whether it's GPI, whether it's subthalamic nucleus, whether it's thalamus, whether it's for dystonia. So consistent results and an improved safety profile as we're getting more experience with this. HIFU thalamotomy for pain is CE mark approved in Europe. This is Jean Minot's group. They've done a great job in Switzerland. And this is for central lateral nucleus for chronic neuropathic pain. And they've shown clinical response to 30 to 100% and very similar to what we see with DBS. And it's an outpatient procedure, very effective results with CL thalamotomy. Capsulotomy and depression. So this is, again, limited number of studies, severe treatment-resistant OCD, very similar inclusion-exclusion as to our DBS cohort, assessing Yale-Brown obsessive compulsive score, Hamilton depression, Hamilton anxiety, CGIs. The target is the different than DBS target that we use typically. It's bilateral anterior internal capsule, 7 to 9 millimeters anterior to the anterior commissure, 10 to 12 from the midline, and you create a elliptical lesion along the shaft of the internal capsule, and very similar to lesioning, but it's different than the DBS targets. Very encouraging results. The Jin Wu Chang and the Korean group are very experienced in this. This is a double shot capsulotomy, like a gamma knife capsulotomy, and the results, very good results, published 2018, 24 months, 54 patients were responders for Y-box for capsulotomies. That's a standard scale. 63% responders for Hamilton depression, Hamilton anxiety, 72% responders, and the mean GAF score showed improvements. These are very good results as comparable to DBS. All results of HIFU are comparable to DBS. And adverse effect profile, really nice, no significant adverse effects that they've seen here, such as hypomania, personality changes in this group published in Biological Psychiatry and Psychiatry and Neuroscience. And this is a depression study. This is a different target. DBS trial failed for depression in this target, but they're showing interesting results of Hamilton depression, scores decreasing from 26 to 8 at week 1, and then progressively getting better. So interesting single case. The Toronto Sunnybrook group recently published in last year Molecular Psychiatry. They showed similar results at the Korea group, doing HIFU capsulotomy for OCD and depression, and very good results for OCD, depression to be determined. So I think OCD is very effective for severe treatment of refractive OCD. I think capsulotomy should be done, but it's not FDA approved. I want to emphasize that. And continuing on, now I'm going to switch gears to focused ultrasound for BBB opening. Any questions about lesioning right now I can answer, or should I continue to BBB opening? Or do we get to questions at the end?
Yeah, I keep going.
Okay, very good. So this is an area that's very interesting. And we've been doing this for 3 years with animal studies and human studies. And I think this has tremendous applications for neurosurgeons with Alzheimer's, glioblastoma, Parkinson's, and many other neurodegenerative conditions. I think this is one of the most exciting parts of this. And BBB opening, we use a low intensity system. It's not a high intensity system, hence we call it LIFU. And we also have to inject intravenous microbubbles while we're doing the ultrasound treatment. And that causes the mechanical disruption of the endothelial cells, the tight junctions temporarily, if you will, and allows extravasation of serum and other materials and not blood, red blood cells into the interstitial of the brain. And as you all know, BBB is one of the big areas for all neurosurgeons. And the BBB is a diffusion barrier and limits access of many substances. And you can see the endothelial cells here in the cross section, again, with the tight junctions here. And they are very unique, as you all know, from a histological anatomy. You have the astrocytes there and you have the parasites. And the tight junctions are present between the cerebral endothelial cells, forming a diffusion barrier. And that's the BBB. BBB is a big problem, is a big bottleneck in brain drug development, and more than 98% of small molecule drugs do not cross the blood-brain barrier, and virtually all of the large molecule drugs do not cross the blood-brain barrier, and less than 1% of drug companies have a BBB drug targeting program, hence an opportunity of significance for neurosurgeons to be working with biopharma. Just some size comparison. BBB does not allow particles larger than 400 to 500 Daltons to cross. As an example, glucose is 180, sucrose 340, gadolinium magnivis is 900. And you can see when you get higher, siRNA is 13,000, peptides are 3,000, and antibodies 150 kilodaltons. And viruses are larger in gene therapy. So as you can see, anything other than small molecules does not cross. And most treatments that we give for the nervous system, most drugs are average size 357 Daltons and very limited crossing for anything above 500 Daltons across the blood-brain barrier. So what has been done in neurosurgery over the years, osmotic chemical disruption, there's cell-based delivery, intranasal or direct infusion, conventional enhanced delivery, opening up mannitol and other activities going on. Great work, but there's a lot of limitations, invasive procedure, higher dosing, limited spatial resolution. So this is where I think ultrasound is very innovative. And here's basically what happens in a brief video that shows this here.
Deep inside the brain is a shield that protects against invaders. It's called the blood-brain barrier. It allows nutrients to reach brain cells from the bloodstream while filtering out germs and other harmful substances. But there's a downside. Drugs needed to treat brain diseases too often can't get through either. The blood-brain barrier is made up of cells that line most of the brain's smallest blood vessels. Those endothelial cells are tightly packed together, so only small molecules slip by. Many drugs for cancer, Alzheimer's, and other brain diseases are too big to easily pass through. But what if scientists could make the blood-brain barrier temporarily leak in just the right spot in hopes of one day helping those medicines sneak inside? To try, they inject microscopic bubbles into the bloodstream. MRI scans pinpoint the desired brain location. Then researchers beam what's called focused ultrasound right at that spot. The ultrasound waves make the microbubbles vibrate, creating a temporary opening in the blood-brain barrier. An experiment with a handful of Alzheimer's patients shows the barrier opened, let some harmless dye seep in, and then sealed back up. Similar small safety tests are getting underway with brain tumor patients and people with leukemia.
So what happens is that it's a low intensity system and delivers 1% of the power effectively of the high intensity system, is much safer. So it's really that opens up a lot of possibilities for safety for us. And low energy ultrasound, when it interacts with the microbubbles, causes mechanical disruption, if you will, and temporary opening of the blood-brain barrier. And so this is based on years of preclinical studies that optimize the safety, dosing, and looking at various monkeys and rabbits and mice studies, and being able to come up with the optimal dose, if you will, of how you deliver. If you give too high a dose, for example, you're going to bust open the endothelial cells. You're going to get bleeding in the brain. So you cannot give too high a dose, but within the proper doses, it can be very safe. The AD, Alzheimer's mouse models, studies have shown the blood-brain barrier open with ultrasound, amyloid plaque reduced and behavior improved. There's also been neurogenesis that's been showed, increase autophagy, you can see, and arborization that's seen in some of these studies. But again, you have to translate from rats and mice to humans. That's a big thing, right? Other great studies doing with ultrasound preclinical. They've shown reduction in plaques, and they've seen endogenous antibodies, IgG and IgM antibodies with FUS now going inside. Albumin goes into the interstitium from the serum and it attaches, some studies show they attach to the beta amyloid, and that facilitates the phagocytosis and removal of some of these, or the breakdown of some of these. Other studies in Australia, great group there. This is scanning ultrasound device in animals, show 75% reduction in plaque and improved memory. Those are animal studies. A lot more animal studies, but let's talk about humans now. Alzheimer's, as you all know, a big problem with no effective treatment, and 1 in 3 seniors dies with dementia or Alzheimer's. Big problem, numbers are growing very significantly. When you look at the pipeline of Alzheimer's disease, and I think Alzheimer's is now a neurosurgical disease that we can be working on, whether it's DBS or gene therapy or other approaches. So disease-modifying therapies are the vast majority: anti-amyloid, anti-beta amyloid, anti-tau. There is symptom cognitive enhancement, acetylcholinesterase inhibitors, or neuropsychiatric systems improvement symptoms, but there's no cure, and 99.6% failure rate so far. This is a chart from a great paper, shows phase 1, phase 2, and phase 3 studies looking at the mechanism of the amyloid, tau-related other treatments. And again, despite 1,000 different trials and billions spent, only recently got an FDA approval of adenosine, which has been also very controversial right here with the Biogen drug. There's a Lilly drug and others, but this is a controversial one right now, but we'll talk about that in a second. So human studies. First study was published by the Sunnybrook group, and they showed 5 patients published in Nature Communications where they did the frontal lobe, and this was purely a safety study where they opened the frontal lobe blood-brain barrier and closed again. Then came our study, which we're doing with Mike and our team and the Ohio State team, as a phase 2 safety and efficacy in mild AD, targeting hippocampus, entorhinal cortex, frontal and parietal lobes, positive for amyloid beta. And that's 18 patients to date enrolled. We've enrolled 9, 6 at Ohio State and 3 at Cornell. The study sponsor was in Cytec, is an FDA IDE, and the goal is safe opening the BBB in large volumes of hippocampus, frontal and parietal lobes. And we want to evaluate a reduction in beta amyloid with PET scan in these individuals. And then also evaluate reduction in clinical deterioration. Each subject got 3 treatments. So over each 2 weeks apart, 3 different ultrasound sonications, head frame applied, shaved the hair, head frame applied, shaved the hair. So it's a lot of work, and these very challenging people who are really very compromised. Stereotactic head frame, shaving of hair. Our last 2 subjects, we did not shave the hair. That's a new innovation. So we're moving towards shaveless and frameless within 1 year. I think that's going to open up tremendously the opportunity for your patients coming into the MRI without a frame. It's a bite block. Without shaving your head, you can get focused ultrasound BBB opening treatments coupled with medications, drugs, and others, and go home same day. So that really opens the whole field because you don't need a frame anymore or shave the hair. Anatomical targeting, and then we use the low intensity 220 kilohertz system, and you inject or you give a drip of intravenous microbubble Definity, which is used for cardiac imaging. We do in the brain. So here's an example of the first subject we did in October of 2018, targeting the amyloid-rich regions in hippocampus here. You can see our targets 5 by 5 by 7 millimeter boxes that we treated. And you can see here an example of the treatment of the left hippocampus here that we did. Microbubbles are injected. And you can see here, that's the ultrasound coming in and the microbubbles to the hippocampus. And you can see baseline. Immediately after we open the blood-brain barrier, there's gadolinium contrast enhancement. And then 24 hours later, it's gone. Another subject, immediate enhancement, gone 24 hours. And other subjects, immediate enhancement within minutes, and then gone 24 hours. Left hippocampus, entorhinal cortex, again, the same thing we see. So this paper that we published with Mike and the group in PNAS last year showed that we're able to open up 95% of the targeted FUS regions in the brain. We opened the blood-brain barrier, and that was essentially 30% of the overall hippocampus entorhinal cortex volume. Based on that, the FDA said, go ahead and open up larger volumes and go into 30 and 40 cc's in the brain to frontal parietal lobes. So hence we did, and we did a 30 cc. You can see your hippocampus area opening, frontal lobes. In this case, these areas very rich in beta amyloid, and the parietal lobe, posterior cingulate lobe, precuneus areas involved in spatial orientation, and we opened up the blood-brain barrier. And we're able to do reversible on-demand opening. Every time is fully reversible, and 75% of the treated volume, you open the blood-brain barrier. So imagine if you target 40 cc's in the brain, you can open 30 cc's or more in a brain of an Alzheimer's patient. It's very different than brain tumors because you can open up a larger volume of the brain, but the BBB is disrupted differently. This is in Alzheimer's brain patients. GRE signal, you can see these dots. Immediately after we open the blood-brain barrier, you can see the T2 star, and that is the blood-brain barrier opening with the individual spots. 24 hours later, it's gone here. So you can see these are micro hemorrhages, if we want to call it that, or micro changes in the brain that we see in the volume targeted, the left frontal lobe, for example, but the signals go away. If you give too high a dose, they stay, and you can get micro hemorrhages as well. Our initial results, 10 patients, 8 here and 2 in Cornell, that received 30 treatments. 32 months was a longer follow-up. We compared to an ADNI comparator group, and we saw the numbers are very small, but we're seeing a very simple and stable sort of progression. They are progressing, but it's relatively stable, and it seems to be a little better than the comparator group, but the numbers are very small, so I don't want to make any definitive conclusions, but no worse than a comparator group that's age and sex and imaging matched, and maybe a trend towards having less progression, but we need more numbers. So these data are quite interesting for us. What happens to beta amyloid plaques here? And this is another paper we published looking at baseline in comparison to 90 days. We saw within 90 days, average of 3.4% reduction in plaques in the treated region. And we looked at 1 year, it moved up to 10% reduction in the beta amyloid plaques in the region. And one of the mechanisms is a paper we published in radiology that looked at activation of the lymphatics. So we think high likelihood that we're activating the lymphatics and this immune surveillance mechanism in the brain that's facilitating the clearance of these metabolites or these proteins that are modified after the BBB opening, or facilitating removal of these mediators. So mechanisms, multifactorial, still being studied, obviously. Studies show local induction of inflammation. We're getting a local ARIA, if you will, and immunological activation and modulation. Neutrophil and microglia recruitment are seen to the focused areas with BBB opening, and intravascular protein gain access to the brain. Albumin gets in, and that is likely causing activation of the immune system. And albumin links to the beta amyloid. And you also have enhanced brain removal and clearance with pathological proteins. And also some centers think that you're breaking down the plaques, the beta amyloid, into smaller proteins that can be more soluble and can be more coming out of the brain now. Summary, in our first 10 subjects with long-term outcomes across frontal, parietal, and hippocampus, we're able to open the blood-brain barrier immediately, transiently, and on demand, and it goes away and it's closed in 24 hours. We achieved 85% of the target treatment zone overall in all the regions, and up to 30 cc's of the Alzheimer's brain we were able to open. We're going to 40 now. We saw no hemorrhage or adverse events up to 33 months follow-up, and no deterioration in neurological cognitive function as compared to an ADNI comparator cohort. And we're seeing reduction in PET signals. We're doing a centiloid analysis, which is much more sensitive, and we're seeing reduction in all subjects with PET scan. Next steps, complete the study in 20 subjects with 60 treatments that will be done. We're subject 18. The last treatment of that is next week for us, and then 2 more subjects. And we got to evaluate long-term safety, evaluate beta amyloid, tau PET, expansion of brain location, expansion volumes of 40 centimeters cubed in Alzheimer's. We got to look at the characteristics of the mass, size, shape, kinetics, and clearance, and the kinetics of various therapeutics, whether it's viruses that Mike is looking at, or antibodies, or enzymes, or growth factors, and all of that. That's an important study, preclinical. And linking very critically, opening up the blood-brain barrier with the targeted on-demand delivery, immunotherapy, growth factor therapy, gene therapy, and other therapeutics. That's the biggest opportunity in functional neurosurgery. This is the group with Mike's team, Levi, and our team here, and also at Sheba University and Vanderbilt, who are working with the PET scanning with us, with Dan Klassen. And then another interesting is this aducanumab. You all saw this. There's a lot of controversy about this, but for the first time, FDA approved the medication, an antibody, anti-amyloid for Alzheimer's based on a PET signal. So clinically, it was equivocal, but based on a significant reduction in the amyloid beta plaques in the brain, they approved this for FDA. And this is an interesting situation right now, $50,000, $60,000 per patient once a month, 12 to 18 months. Imagine if you have 100,000 people getting this, which is a small number, who have MCIs or early Alzheimer's, that will be $50 billion to healthcare systems. So Eli Lilly is coming up with their phase 3 trial. So this is going to change the curve. And what do you do it ethically with people that have early Alzheimer's? So interesting time coming up right now. But this is a great study recently came out and looked at, this is the Australian group in animal models. They combined blood-brain barrier opening with FUS with adenosine. So they use the same adenosine here and adulam, and they saw a 5-fold higher concentration in the brain. And this was seen in the cortex, but not the hippocampus. So this really opens up a new area where we can link this FDA-approved drug now to a focused ultrasound technology. So they conclude that ultrasound should be considered as a treatment option for AD, or combining use of adenosine with ultrasound to increase brain levels of the antibody. Another study published in Nature Communications now looks at Parkinson's. Great study. Obeso's group, they looked at those with PD, Parkinson's, who had dementia by opening up the blood-brain barrier. This is not a motor target, but because Parkinson's patients also have beta amyloid, alpha, and synuclein, and they showed that the BBB opened in 8 of the 10 patients, and they showed mild cognitive improvements. Don't know what that means. Interesting, but maybe it's beta amyloid, maybe it's alpha synuclein, maybe it's a more of a clearance of lymphatics, but interesting results very early on in Parkinson's, and they're looking at Huntington's as well, just opening the BBB. But I think the biggest opportunity is targeting it to other compounds. So glioblastoma, this is a lot of tumor surgeons here. So FUS increases delivery, preclinical studies with Herceptin, methotrexate, temozolomide, Avastin. These are all published studies. And initial studies that came out showed 5 patients with high-grade glioma had FUS and chemotherapy 1 day prior to the scheduled resection. And then when they did the biochemical analysis of the resected tissue, they saw the sonic A tissue had chemotherapy agent in it. Subsequently, the Korean group did a nice study with 6 patients with GBM with temozolomide, and they showed BBB opening disruption was observed in 134 targets in the GBM in these patients. And that led to the 6-patient temozolomide cycle with GBM. And this is the 1-year outcome. Again, 1-year outcome, small number of people. Survival rate of 1 year was 100%, and 2 patients showed a recurrence of tumor at 11 and 16 months. And none of them had any complications related to the immediate blood-brain barrier opening. This led to the FDA trial that we're doing now with University of Maryland, Brigham and Women's, and UVA. This is the temozolomide 6 cycles. And this is our second subject here. You can see we got opening of the blood-brain barrier in the subject here, but this requires 6 cycles, and this is the FDA clinical trial. Carboplatin, and again, preclinical models showed that the mice that were treated for 4 weeks and carboplatin plus ultrasound enhanced survival and delayed tumor growth as compared to carboplatin alone. Interesting, and that led to the recurrent GBM and carboplatin study, which is a Cleveland Clinic, University of Maryland, Stanford, NYU, and Sunnybrook, Israel, and Korea study that are doing this for 30 patients with blood-brain barrier disruption with carboplatin chemotherapy coupled to blood-brain barrier opening. Another study, which is a different technology, Carthera, this is not FDA approved, but is used in France, the Burhole device. Good study that showed blood-brain barrier opening and really looking at the survival of 4.1 months and 12.94 versus the group with no or poor BBB opening. And this is looking at BBB opening with carboplatin, and this is the Burhole device, different than the Incytec device that we use. This is another study. This came out of the Columbia group, very nice study looking at pontine glioma with scientific reports. Study that showed focused ultrasound increases intratumoral etoposide more than 5-fold. Interesting, we're seeing always 5 to 7-fold in preclinical and some early clinical studies of different therapeutics in the brain. I think Jim Rutka is looking at pontine gliomas also in pediatrics in Toronto. So a lot of studies are looking at these diffuse gliomas and targeted delivery of chemotherapy or other agents. So it's exciting times, I think, to see if these can help the survival and benefit in the people with brain tumors. Gene therapy. And again, this is looking at Parkinson's AAV particles. And this is a short hair RNA against the alpha-synuclein. And they showed that 40 to 60% reduction in alpha-synuclein 1 month post-FUS AAV injection. And it was localized to sonicated regions only. There was no expression in the contralateral hemisphere. Mike's group has done great work, and Mike is a leader in gene therapy in the world for this and other applications. And he showed 50 to 75% of striatal neurons transduced on average. Very nice study with AAV. And you saw the GFP transgene expression was stable up to 6 months and ongoing expression for 16 months. So it's really good. Open the blood-brain barrier, deliver your targeted payload of virus, gene therapy, whatever you want, and then the barrier closes. We got to look at the what happens over time, but this is a very nice study published by Mike's team. And let's not forget about stem cells. And this is Kalervo and others, +1. They looked at stem cells, and then the Korean group, where they showed increase in mesenchymal stem cells with FUS going into the brain, and they're seeing stem cells going in as well by 2-fold. So you see 2-fold stem cells from the studies, 5 to 7-fold increase looking at chemotherapy or antibodies. Last 2 slides. So I went very quickly through many applications, but here's where we are. Focused ultrasound technology. We've been doing it for 5 years. I think it's an area that's going to continue to grow. It's providing a new opportunity for neurosurgeons. MRI is no longer only a diagnostic technology, but is a treatment tool as well. FDA approved for Parkinson tremor, bilateral tremor coming very soon for FDA. And to be determined, Parkinson's, GPI, and subthalamus, dystonia, epilepsy, chronic pain, OCD, and depression, all undergoing research, various phases of clinical trials. BBB opening, clinical trials in Alzheimer's, expansion of the trials are ongoing now. Parkinson's and targeted delivery in brain tumors, and neuromodulation trials in movement disorders, TBI, and opioid addiction. So I think there's a tremendous opportunity for research innovations now in neurosurgery, where now you can deliver the medication, growth factor, enzyme replacement, antibody, genome, stem cell, anywhere in the brain, cortex, subcortical area, hippocampus, midbrain, pontine area with precision and safety using the current technology. So I think this opens up a tremendous opportunity for neurosurgeons. So I'll stop, and I appreciate the invitation to speak to this esteemed group here.
Oh, sorry.
Ali, that was a great talk, great survey, as always, as expected from you. Quick question, have you done any work at looking at, and I've talked with Mike about this as well, is really looking at what it is doing to the blood-brain barrier? We say that it breaks it down, and you obviously have evidence of it, Mike has evidence of it. But do you think we need a better histological and electron microscopic analysis of that?
We do. We really need to understand the mechanism. The other thing that's important is to maybe radio label antibodies, other tracers in humans, and follow distribution. We need to find out what happens over time. Yeah. And the paper that I showed you with the lymphatics, we did 17 MRIs on one subject sequentially, and at least 10 different contrast doses to see what happens. So we need these kind of studies to be done, but I agree with you. We need to find out what's going on histologically. It's given the current doses, it seems to be safe where we can open it and it closes within 24 to 48 hours. If you give too high a dose, you get bleeding. So you got to be careful. But I think the doses for BBB opening are very stable from my point of view, at least in Alzheimer's brain, who have a disrupted blood-brain barrier to begin with. So, and Mike can comment, he's been looking at this in primates as well, but I think it's a very fascinating area, Phil, in terms of for the future. I think opens up possibilities for all types of neurosurgeons, not just functional neurosurgeons.
But also opens the question of why does it recover over time? What actually is happening, and how could we use that to our advantage in other disease processes?
You got it. You got it. And it's interesting. Yeah.
So I'll leave it.
Yes.
To build on Phil's point, I was going to ask you, I know that you guys have seen this and we've recently seen this, that there seem to be differences in the tissue responses in different brain regions to the same amount of energy delivery, et cetera, in terms of the severity and longevity of the blood-brain barrier opening. So, I mean, clearly, I think with both BBB opening and with lesioning, we only understand a very limited number of parameters that actually influence this stuff, right? We focus on skull density, there's a lot more to this, and we all know it. In terms of these tissue differences, what are your thoughts as to what might be influencing why these, like the frontal lobe responds differently than the hippocampus, let's say?
It's a great question. I think that it may have to do with the microvasculature, the flow of the microvasculature. I mean, in hippocampus, we also may have sinks of areas, like we go across hippocampus, we go across ventricles a lot. We go a lot across sulcal surfaces, peel surfaces, multiple gyrations. It's a great question. You know, the dosing, as Mike said, the dose that we use in hippocampus, if we use the same dose in Alzheimer's in the frontal lobe, you may get a brain hemorrhage or you may get edema, swelling. So certain areas, maybe a depth issue, Mike, in terms of being on the surface and all that, I don't know at this point, but I think it's a function of the tissue, frontal lobe tissue versus hippocampus tissue. I think the sulcal gyral patterns may require higher doses to be given to see the effects. And you also have ventricles there. So you're going across multiple ventricle spaces.
Yeah, and I think, you know, to your point, I think one of the mistakes that need to be avoided is to try to generalize too much from specific situations. So much of until, you know, you started doing the Alzheimer's study and then we joined in and, you know, obviously, you know, we've been doing a lot of stuff in animals. The vast majority of BBB opening, as you said, is from tumor work, right? Well, most of those tumor patients, until they had a tumor, were not particularly atrophic or anything. When we start doing degenerative patients, if things like the local vasculature, the status of the local vasculature, the level of CSF versus, you know, tissue, et cetera, are going to influence things, I think we got to understand all that, because that's going to vary quite a bit from patient to patient. A degenerative disease with older patients compared to, you know, middle-aged patients with a brain tumor, where they're not going to be nearly as variable.
You got it. And that's a tremendous area for grants and research and needs to be looked at. I think the Parkinson study that was published in Nature is really interesting also, Mike. You saw that shows they opened up the BBB in the parietal occipital areas and they had improvements in the cognitive aspects of Parkinson's. So now, you know, it's not only Alzheimer's, we're looking at many degenerative diseases. Right. But I think gene therapy is really important, and to really give these genes without opening the head and deliver it. So this really expands the domain of neurosurgeons. I think it's a great time for becoming involved. Are you getting a second unit there in Columbia and Cornell? How many units do you have there now? We're
getting a second unit for lesioning that both campuses are going to use starting, it's being installed next month.
Yeah, and I know NYU has a high and low intensity, and they got in the carboplatin study, and Brian Coppell also at Mount Sinai, they're getting this. So I think it's a big area, but Mike is right. It needs to be guided by animal studies, and Phil is right, looking at histology and what's happening exactly. We have a rough idea of safety, and we've been fortunate so far, but we need to do more patients. I mean, it's only been 20 patients ballpark we've done for Alzheimer's. So, but it's interesting, the plaques are progressively declining as you do compare 90 days to 1 year. So something is progressively occurring, because we only treated them 3 times, but 1 year later, they have more progression in their plaque reduction. So, What do some of the tumor folks think about this on this call? Any thoughts from the tumor colleagues? What are your interests? Or I don't know if Mark Sudan is on pediatric pontine glioma and others. What are some of your thoughts? To be determined. Okay.
Sorry, I'm not one of the attendings. I'm one of the neurosurgery residents at Cornell. But I think it's really interesting, and I actually wanted to apply it. I just started my research time, and I think it would be interesting to apply it and to see how much tissue penetrance you get. And it's interesting to hear that depending on where it is, you might be able to get. It might be variable in regards to tissue penetrance for the tumor, but also how steroids will affect it, because that's been shown to affect the extracellular environment, and that'll change the density, and that might also change the tissue penetrance, even with the focus ultrasound.
Yeah. Well, and you have Mike Kalp, a tremendous mentor there. I mean, Mike is a world's expert, been doing this with clinical and preclinical. So Mike is a tremendous resource there for you guys to do. And now you're getting Gordon also. Sandra, come on. So Gordon, so now you have two top people there who are super experienced in focused ultrasound.
Ollie, can you talk to me a little bit about the frameless and hairless? That's, I live in New York, and I'm all about frameless and hairless.
Yes.
Or shaveless, I should say.
Shaveless, yes. So the high intensity where you need precision, where you make a lesion in the brain with 1 millimeter precision, you need a frame for that, and you have to shave the head. So high tremor, you have to shave the head. The shaveless is being done for low intensity now, which is Alzheimer's. Mikey did a patient, I think, shaveless, and we did one also too. So now it's FDA has given green light for low intensity to do shave. So you can basically up to 10 centimeters of hair you can have. You don't need to shave the hair. And by end of this year, you're going to get frameless with a bite block that they're taking to the FDA right now. If that happens, I think that changes the game, because the MRI in a helmet becomes a therapeutic tool right there. So you can open the BBB for your brain tumor protocol, for your gene therapy protocol, and other protocols. And I think that really opens it up. So the answer to your question is, in a year from now, I think virtually all low intensity treatments will be done shaveless and frameless. And that really opens it up, because Mike knows these are Alzheimer's patients, 75-year-old, very fragile ladies. They have very small head. Imagine every 2 weeks shaving their head, putting the head frame on. It's not easy, and they don't like it. But low intensity BBB opening and neuromodulation, it's going to be shaveless and frameless within 6 months for everybody, which I think is great, as you're saying, Sandra.
Awesome. Thanks.
Yep. Are you planning on doing things there and in Columbia with some of these research studies also?
Yeah, I mean, we're collaborating with Mike and Gordon, and Brett's on the line right here, and he's going to be leading some efforts. And obviously the bioengineers are very interested in it here. Lise Kanafoglu and her group. Yeah.
Yes, I think she started the trial also for Alzheimer's. I think she's using a one phase system. Is a different system. It's not the FDA system we're using, but I think that's great. The more we do, the more we can learn. I think she got good results from that, from the biomedical engineer. I didn't know the results yet of that.
Brett, do you know?
I think they've only enrolled one patient so far. I don't think we have results yet. I had a question actually about the lesioning, the low temperature test lesions. How do we have good data on how reliable that is in predicting what the effect of the permanent lesion will be? Or is that mostly just anecdotal from experience at this point?
I think that the data is very reliable. I mean, it goes from all the RF lesioning days that we did, where we did testing to see if there's a temporary reduction in tremor, and it's really to make sure there's a benefits and really for side effects. So we do 42 to 47 degrees. Those are reversible. And very reliable. I mean, Mike, what do you think? You've done tremendous number also. What's your thoughts?
Yeah, I mean, the company actually has a tremendous amount of data that suggests that you're roughly around 50 degrees. Whatever spot you get around 50 degrees ultimately predicts your final lesion size, but that's a bit misleading. because it's not that 50 degrees is enough. It's that whatever that spot is at 50 degrees winds up predicting what your final lesion size is going to be when you hit 55 to 60 degrees. And so and so there is pretty good data about that being fairly predictive, but it is still an iterative process, you know.
And the other thing is that people go home within a couple of hours. I mean, it's really amazing. They come in, they go home within a couple of hours. So it's really changing the way we do neurosurgery in some ways. I mean, it's like an outpatient treatment without really surgery. So it's interesting. The actual cutting of skin is what I mean. The good news is done by neurosurgeons. So that's really good. FDA has mandated it has to be done by neurosurgeons that are treatment people. So really good.
Yeah, I think to your point, Ali, the one dirty little secret that as functional neurosurgeons we've never wanted to admit that's been dramatic, in my opinion, with these patients, is that even a simple burr hole, I think, creates a fair amount of cerebritis. And I think these patients, I'm not saying they're never the same again. They go back to relatively their baseline, but I do think that that when we don't open the head, the reason we send these patients home the same day is because they are so remarkably unaffected by this thing compared to even just opening a burr hole. And I think it's because when you lose CSF and you get products in and air in and whatever, their brain is not the same. So it is remarkable how well they do.
Yeah.
Dr. Rezai, that was very nice. But I do tumors here at Cornell as well. I think one area that I don't know what your thoughts are, that where this may be extremely helpful will be in the area of low-grade gliomas, where the blood-brain barrier is competent, right? We have chemotherapy agents that are fairly efficient in vitro, right? And in preclinical studies. And then when they get to the patients, they fail to work simply because of that. So if we had, this would be a nice way to permeabilize basically the blood-brain barrier and then get the agents to them. I think that's a very, very fertile area that should be looked into.
100%. I think that the FDA initially wanted the glioblastomas, GBMs. Because as we all know, there's really very challenging future for those patients. But I definitely think, I agree with you. I think GBMs are very challenging with the BBB disruption around the tumor as well. But I do think it's going to march more towards lower grade as well and some more elegant study designs. I think temozolomide is an interesting study, but maybe not the best. Carboplatin is more interesting and others, I think so. A lot of opportunities here in the brain tumor world where you can on demand open the blood-brain barrier without shaving, without a frame, and deliver your agent.
I think you're supposed to be with the residents, right? I just don't want to
okay.
take too much.
Okay.
No, I don't know. That's what I saw something on the calendar. Is that true? Do you know?
Yes, the residents are ready to meet anytime. We can give Dr. Rezai a short break, and then they're ready to meet him.
Thank you all.
Thanks, Ollie.
See you, colleagues.
Take care. Thanks.
Sure, everybody. Thank you so much. Do I get on a different, or do I stay here, or do I get on a different one?
No, you can go ahead and stay on here. So
all right. Please
feel free to take a break and get some water.
Oh, it's cool. It's cool, yeah.
The residents will be here, I'm sure. Thank you so much. I know it's a long hour.
No, it's good. I appreciate it. It's seeing the old colleagues. It brings back memories seeing Mark Sudane.
Well, they were all very eager to see you. So, I wish we could have hosted you in person, but that more in the future, there's more opportunities.
No, it's good.
So so if you want to maybe take 5 minutes, I think we'll let the residents trickle in and then get started.
Sounds good.
Andrew.
Yes, hello.
Hey, how are you?
Good, how are you?
Thanks. You guys are
No,
you guys all together here at MSK.
I have, yes.
Oh, the illustrious.
Yeah.
Great. Okay, great. All right, so Andrew, Graham, Garrett, do you guys are there any cases that you want to present, or do you want to just get started by introducing yourselves maybe to Dr. Rezai?
We can start with introductions.
Great. So, Andrew, you want to get started? Andrew's at MSK right now, but he's one of our Cornell residents.
Yeah. Hey, Dr. Rezai, thanks so much for that talk. That was awesome. I'm one of the PGY, I guess, 3s now at Cornell, and we rotate over at MSK. We send like a junior resident and a chief resident every month. So I'm here with my chief.
Hey, I'm Alex. I'm one of the PGY 6s now.
Nice to meet you. Do you guys still work with Mike Caplet there?
Yeah, we do.
Yeah,
for sure.
You go to the ultrasound, or you guys run away from that? It's not real surgery, huh?
No, we don't run away from the ultrasound. Most of what he does on the main campus, at least, is his surgical stuff. But we go over to see his focused ultrasound every couple of months. So
yeah, he's really outstanding and doing some cool work with the primates and also with the Alzheimer's. So
yeah, nobody gets more excited about his case the night beforehand than Mike Caplet. If you start texting him about if he's doing a DBS for post-stroke pain or something like that, he gets very, very fired up and excited to talk about it.
Yeah, I forgot to ask him. He had a study with the DBS for cocaine addiction. Is he still doing that or not? Because we have a study we're doing for opioid addiction here with DBS in the nucleus accumbens. Is he still doing that there or no?
I don't know if he's researching it. I can't say that I've seen us operate on that, but I'm sure he's got his.
Yeah, they actually had a lot of trouble recruiting isolated cocaine abusers, and then they reapplied for the IRB for polysubstance abuse, and the resident doing that study graduated, and it's just kind of stalled out a little bit, but he's still interested in it.
Yeah. We did we've done DBS, and it's interesting for opioid addicts, and we're seeing reductions in cravings with accumbens deep brain stimulation, because we're increasing the dopamine baseline in the accumbens, so they don't need to be seeking drugs to get their dopamine, and they're getting the